Thank you for the doctor, and especially thanks to Dr. Malcolm, and it's my honor. Okay, today my topic is endoscopic extreme TLIF surgery for large cage. I came from South Korea, and this Surgeries and the vision. Okay, is it possible to put a large only cage under endoscopic TLIF procedure? Let's see. There are various surgical approaches for lumbar fusion, as you know: PLIF, TLIF, XLIF, ORLIF, or ALIF surgery. But I think the goal of spine fusion surgery should be like this. Number one is we have to decompress the posterolateral region, and we have to do bone-to-bone fusion. And if possible, we have to restore the spine balance. For better spine fusion, precise and gentle end preparation will be necessary. Also, a large interbody spacer would be better than small. For balance, proper cage position is very important. Sometimes we use bone materials, orthobone and DPM and BMP or I-factor. Well, I did many endoscopic fusion surgeries, but whenever I'm doing that, I feel some limitations. The small cage footprint, the cage is too small. Okay? So I cannot correct lumbar lordosis. Lumbar lordosis correction is not easy. Okay? But sometimes I can complete end preparation. For good surgical, for good coronary sagittal balance, cage size and cage position is important. Let's look at the cage size first. The bigger cage would be the better. As you know, TLIF cages width is 11 and 13, and length is 28, 32, and some company made 38 millimeter. XLIF only cage already produce width 18 and 20, 22 millimeter, and length is 40 and 45 and 50. In this picture, you can see the difference. Next, cage position is very important. According to the Alexander Abusi article, unfortunately, the center of endoplate is the weakest spot. You can see the endoscopic TLIF postoperative MRI view. This is not bad, but the cage is very small. So I use the banana cage, but not good, I think. But this is actually cage. Okay. I think a good cage position should be like this. In the AP view, the cage from pedicle to pedicle. In the sagittal view, the center of the cage should be anterior to the center of the body. For better spinal fusion and correction, among this surgery, I think the ORLIF surgery is the best. But ORLIF surgery, whenever doing ORLIF surgery, we have to worry about vascular injury and spastic train injury and urinary tract and peritoneal injury. And ORLIF surgery is not so easy technique for ordinary spine surgeons, especially in the level of L5 level. And we cannot do posterior decompression. Also, we cannot use orthobone. For posterior decompression, we need to change position. But some surgeons recently doing this job in lateral position, but it's not easy. So I think under TLIF procedure, because TLIF procedure is familiar to spine surgeon, so if I can put large cage, like ORLIF and XLIF cage, would be better procedure. So I review the Cambridge triangle. According to this article, read article, L1-2 level, the base is 12, L2-3 level 13, L3-4 level 17, and L4-5 level 18. But there is no data L5S1 level. So you can see the 18 or 17. So only cage, the size is 18 or 20, 22. So I think I can put the only cage at least in the level of L34 and L45 level. So I have to make operative corridor. I removed facet joint completely. So I extended Cambridge triangle. So I call it length of extended Cambridge triangle. So L34 level may be larger than the 17, L4-5 level rather than the 18. L5-S7 level, fortunately, the facet joint width is very large. So we can use 18 or 22 large cage. This is an example of a preoperative measurement. I always recommend to check LEK before operation. In this MRI view, L4-5 level, the average is over 18. L5-S7 level, the average is over 20. This is the actual endoscopic view during operation. You can see the extended Cambridge triangle is almost 20 millimeter. So I made an TLIF procedure. Under endoscopic TLIF procedure, I have to do total prostatectomy, and I have to use large cage, same as early cage. And anterior and transverse line of cage will be necessary. And the operative corridor is between the TLIF and XLIF procedure. So I call it XTLIF. Actually, this video made my partner, Dr. He Dong-ah, previous presenter. He's a very excellent endoscopic surgeon. He made this video for me. Okay, this is all about XTLIF procedure. He's very nice. Okay. Indication of XLIF is the same as, I think, the TLIF surgery. I show the cases. Case number 1, 65-year-old male patient, lower pain and left radicular pain. Already he had 6 months ago, he had 6 months ago endoscopic compressive surgery, but there is no improvement. In the MRI, you can see the lateral recess stenosis and L5-S7 foraminal stenosis here. So this is a picture of the end preparation. So we can get enough bone after total prostatectomy. And this is actually transforaminal approach. You can see the L5 exiting route, and this is medial side, and this is discal space. So I do not have to expose the medial side. So this annula is very hard, so I have to use the calcium plunger. The procedure is the same as open surgery, minimally invasive TLIF surgery, the same as. This is a shaver into the L5-S7 discal space. The procedure is the same as TLIF surgery. And I put a only cage into the L5-S7 interbody space without the root damage. This is only cage. Okay, we can see the root is intact. And this is the postoperative X-ray view. The cage is from pedicle to pedicle, and the rhodotic curvature, rhodosis is not bad. Postoperative MRI, you can see the well decompressed state, and you can see the cage position is relatively good. Next case is a 75-year-old female patient with left radiating pain, diagnosed as spondylolisthesis, L4-5, a preoperative MRI. It is a postoperative MRI. You can see the cage location is very good. This is paramedian approach because this patient is L4-5 spondylolisthesis, so I have to decompress central decompression and contralateral decompression. So I approach paramedian approach. So procedure is the same as TLIF surgery. Laminotomy and total prostatectomy. This is L4-5 level. You can see the exiting root here, and you can see the medially, you can see the transverse root here. Already I did the central decompression. And this is steroid. Also, I put a shaver into the L4-5 discal space. And I have to retract the root medially. And I put a trier. I have to check the size, okay? This is 45 and 18. And then I have to put the only cage through this is a cage guide. So we made a special instrument for safe delivery of cage. And this is anterior and transverse line of cage. So you can see the exiting nerve here and transverse nerve here, and you can see the only cage here. Case 3, this is very interesting case. The 75-year-old female patient and low back pain with right leg radiating pain, diagnosed as schwannoma L4-5 level and spondylolisthesis L4-5. So I did XTLIF L4-5 after microscopic removal of schwannoma. A preoperative MRI, you can see the schwannoma L4-5 level, and postoperative MRI, well removed state, and cage position is good, anterior, well located. And this is microscopic decompression picture. And next case is 76-year female patient, pulmonary stenosis L2-3 level, and lumbar stenosis L3-4 level. Some kind of deformity, but L2-3 level, I have to use a TLIF cage because the operative corridor is very small. But I can use the XLI cage, only cage, L3-4 level, because we can get enough corridor for XLI cage. So I think this is surgical tips. I always recommend in case of spondylolisthesis case, unilateral swept tooth osteotomy. We call it SPO or Ponte approach. Okay, not complete, but I try. Okay, and anterior and transverse line of large cage will be necessary, and if possible, anterior distraction and posterior contraction recommend. So we have to make and follow PI-LL mismatch should be less than 9 degrees. The advantage of XTLIF, I think that we can do direct decompression and good for high BMI patient. Because obese patient, there is no problem. I recommend strongly endoscopic decompression. So we can get better coronary and sagittal balance, proper high fusion rate and proper low subsidence rate, and we can avoid vital organ injury. And most important thing, I think, is spine surgeon friendly procedure. Is TLIF surgery is a very spine friendly procedure, so no need to beg up vascular surgeon. Complications may be same as those of TLIF surgery, but technically demanding, not easy technique too. So we have to worry about always the nerve injury. We have to be very careful. I think the upper levels above 2-3 level, I don't recommend. If the LEK is small, less than 15 millimeter, also I don't recommend. We can do multiple level, but takes too long time. So I usually recommend 2 levels. And if you correct lordosis correction, more than 15 degrees, I don't recommend. We have to do open surgery. Present, since December 2019, more than 10 hospitals in Korea, maybe over 200 cases. So Dr. He and I published the first XTLIF article, 2021, February, modified bilateral endoscopic transforaminal lumbar lymphatic fusion using bipolar endoscopic approach. You can use as reference. So XTLIF is possible mission. So we can put large only cage under endoscopic TLIF procedure. So conclusions, the XTLIF procedure provides large interbody fusion bed and spacer compared to those of TLIF surgery. Maybe bigger cages would be better, but still further long-term studies is required. Thank you for your attention. Thank you very much.